Honored to have Dr. Stephen Bailey, who's the Chairman of Medicine at LSU Shreveport, and he's going to talk to us about racial variations in shock presentations and outcomes.
Well, thank you. Again, my congratulations to the organizers, Marwan, I appreciate here, and to the panelists and moderators, Steve, thank you. We have heard a lot about where shock has come over the last several years, and I've been asked to discuss racial variations. And it's difficult. I have no relationships with this talk, but here are my others. It's difficult to talk about an area where we understand that it has evolved so quickly, but all of our data is retrospective by the nature of the data. We have, in fact, we do know about disparities, and we've all heard a lot about that patient demographics, including race, ethnicity, sex, socioeconomic status, are very important determinants of health care, but they impact access, delivery, as well as outcomes. And I'll return to outcomes because I think that's critically important. Significant racial and sex disparities have been documented in patients with all of these acute conditions, whether it's heart failure, stroke, acute myocardial infarction, most recently TAVR. I'll illustrate that in a second because I think it bears on this topic. And how these disparities relate in patients with cardiogenic shock. We've talked about shock, and it's really too large to begin to talk about shock that is obstructive or shock that is primarily myocardial dysfunction from infiltrative disease. And in fact, there's even less data in those areas than in cardiogenic shock. But access, again, and quality of care and healthcare system biases are not only important, but they're just uncertain. So I'm going to go to TAVR, and I'm going to use the Woodland data from here in Houston because it shows some important features about another important area of care that is high dollar and high impact, and that is TAVR rates. And on the left-hand side, you can see age-adjusted TAVR. In the center, you get a sense of Medicaid, which is interesting because we think of Medicare, but majority of these individuals may be Medicaid funded. In fact, that's very true of cardiogenic shock. And then if we match Black and Hispanic, you'll see that the people who actually get TAVR rates are not in the Medicaid areas, and they're not in the Black and Hispanic areas. So we clearly have selection going on in terms of how we are making those decisions in at least one of these other areas. We've seen this, and I think it's very important with the growth that's occurred in our ability to think about how we categorize individuals, phenotype, severity, risk, etc. We've seen this slide, but it's particularly true when we talk about race and ethnicity because it will bear on those as well. The fact that mortality increases with SCAI stage is something that we have also heard about and we'll hear much more about. And I point that out because of the differences in terms of where patients that are not white present and their assessment. So I'd like to simply point out and ask the question of how precise is our assessment of shock between physicians. That's very important. How good are we at assessing it if we're going to talk about what the outcomes are? And then, do individuals present differently with different phenotypes based on race and ethnicity? That's important in terms of what our outcomes are. And do they present at different points in the shock spectrum? And that was a question that was asked, and I don't have an answer for that. I suspect they do, but there's really no data, so we'll check that one off right away. So we know that if we're talking about profiling, that it remains elusive, and you've seen this slide. Let me introduce a follow-up slide to that, which demonstrates variable interpretations of SCAI stages and shock. 3 great programs, 3 great groups of investigators who have 3 completely different histograms in terms of what the assessment was of somebody coming in with shock. Well, imagine how that will play when we're beginning to ask about race and ethnicity and their assessment. Is there data about differences in assessment based on race and ethnicity? There's not. And I don't know how we begin to tease out that given this is our baseline as well. But it's going to be very important and a subject I think we have to address and think about. We've seen this. I think that's important because we've seen how big data may give us subphenotypes, and that's associated with mortality. I think it's really a very interesting way to approach this. I think it may be an important need of using AI, but if we take that and we begin to back that into retrospective data that we've had, here's the Palala's presentation just this year. It's a 2012 to 2017 look at cardiogenic shock just published. And if you look at that, and you look at the midpoint of that, if you look at acute organ failure and look at white, black, and other, remember many of the others, by the way, are actually individuals who cross-identify as black. So other is another term, at least for some of that population. In 2020, 12% of Americans identified as black, 14% identified as a component of black. So that's the percentage that we're dealing with here. But if you'll notice here, multi-organ failure, respiratory failure, hepatic failure, renal failure, the need for hemodialysis, each of those categories are enriched in those individuals in black or other, and those that have the highest risk category as defined by phenotype are enriched. So it's clear that the phenotypic definitions from this retrospective NIH sample is higher in those groups. What about the use of mechanical support? This is Dhruva's data, and you can see here that the use of none in blue, that is medical therapy, we discussed that, is high, but differs. Even medical therapy is lower in those that are African American or others. Certainly there are small differences in black, but a significant difference. And if you look at, interestingly, the microaxial LVAD device, that is at or slightly above, and then others are included in there. So there's even differences in what we're using between the groups. Now, are we using more mechanical support because they're sicker? I showed you that. Interesting question. No answers. So what data do we have to tell us about outcome? Well, we should have some randomized data. We have some NCDR data, but most of what we have are large administrative databases. So randomized data, you've seen this, but look at the numbers. Is it likely that we will be able to tease anything out from a series of trials that include a couple of hundred patients, primarily done, as I'll show you, in areas that are underrepresented for those that have a non-white race and ethnicity? Probably not much there. What about NCDR? We'd love to have data from NCDR. We've seen a little bit of that. But if you look at publications from NCDR, the principal publication is this from 2016. Tim, you were on that one as well. And if you look at that, shock, no shock, you'll see that in the black individual, first of all, it was 7% of the patients enrolled. So that makes me wonder, if there were 12% of the patients that are black, why we're not seeing more included there as well. And the numbers, again, are relatively small. So we do have some retrospective data. The data from Mayo Clinic, I think, is some of the largest with several 100,000 patients. And if you look at that, you begin to tease out some information. So if you look at age, individuals who were non-white males and non-white females were much more likely to be in the older age group. That may reflect access. It may reflect their thoughts about that. I think social determinants play a role. If you look at their payer status, again, this is primarily a Medicare population, heavily influenced by private patients. And I'll give you some insight into that from other areas not included in this. And of course, the Charleston Comorbidity Index varies as well. Well, what about what occurred when they were there? We've talked about interventions. And you'll notice here that angiography, right heart catheterization, invasive ventilation, hemodialysis, all were disproportionately lower in those that were non-white, male and females. And so this is in the setting of admissions for cardiogenic shock. And while our mortality may not be different, you can see these differences in terms of percentage of patients between 2000 and 2014. A marked increase in white men, not the same in women, but a much smaller incidence in non-white men as well. So why is it that we're seeing a difference in that? In hospital, and we've talked about in-hospital and out-of-hospital mortality. We really don't have much data by race and ethnicity out of hospital. So what I have to show you is some of that that's in hospital. And what you'll see is that there is a difference between non-white males. This is reference to white males as our control group. You can see again here, non-white males, non-white females in this group, a significant difference, a 20% increase in in-hospital mortality in those groups. You could ask the question, is that current? Is it what we see today? And from Lina Yakub's publication last year, she was one of our fellows. I'm excited about her being first author on this. I need to call her out for that. But you can see here in a group that is only STEMI, the data I showed you before was both non-STEMI and STEMI data. I think that's important in terms of differences. But you can see here we're beginning to see in the STEMI group not too dissimilar numbers. Black men, roughly 20%, black women, 30%, Hispanic men, Hispanic women. The same differences of mortality in those groups. Their central illustration breaks that down into in-hospital mortality, likelihood of revascularization, support and right heart catheterization, men on top, women on the bottom. And you can see as you go through and look at each of those categories between white and black and white and Hispanic, significant differences in terms of the utilization in a recent data set. Again, it's NIS data, however, so we see differences there. As Dr. Rao said, we are individuals who are intelligent and think about this data and want to evaluate it. I am going to challenge us about NIH data because I don't think it's a good way to look at the question that was posed. So I know all of you are aware of this, but let me pause for somebody that may have not thought about using the National Inpatient Sample data. So it's drawn from a sampling frame that consists of discharge data submitted by partners. So you have to sign up. And its data from non-partner states are missing completely. So if you don't sign up to play the game, you don't get included on the scorecard. And even if you're included in the game, data from partner states are sometimes incomplete because of different state reporting requirements. Okay, so there's a little difference there. It is set, third paragraph down, NIS draws a number of hospitals from the sampling frame required to net a total of 20% of hospitals nationally, and they're designed to reference that. And it's in 4 regions, 3 categories of hospital ownership, urban, rural locations. I'll come back to that, teaching status, bed size. And as a result, the proportion of NIS hospitals in a stratum that are from a given state is unlikely to equal the state's actual proportion of hospitals in that stratum. Consequently, the sample of NIH hospitals is unlikely to be representative of hospitals in that state, and the NIH sample weights will not be appropriate to the state level. So I think if we're thinking about homogenation, trending towards the mean, thinking about the nation as a whole, it makes some sense to use that. But the challenge I would give us is, are we really, if we're worried about race and ethnicity, asking the question in the correct place? Because if some states aren't included, maybe they're the states, perhaps, that you'd want to include in order to answer the question. So let's overlay, and I'm using NCSI. I could use the Cardiogenic Shock Working Group, by the way, because many of those centers are the same. Let me overlay on top of that, from 2020, the most prevalent race and ethnicity groups by county. And if you look at those sites, very few of them actually fall smack into the middle of a county that is likely to be heavily influenced by African Americans or others. So I would submit that as we're talking about trials, if this is an important question for us to raise, Sunil threw out, you guys get to design the trial. I'm throwing out, as we're doing the trial, I think we have to think about how we're doing this. And if it's, in fact, as we're doing strategies for inclusiveness or triage or whatever we're doing, I think we have to be better at that than we've been. So that, I thought I had one slide before that. Can we go back? If not, part of why I am here, because you're looking at the panel going, why is this old white guy standing up there talking about, African Americans? So, I'm currently at LSU Shreveport. We are a safety net hospital system that serves Northwest Louisiana, and 40% of my patients are African American, not 40. 20% of my patients have commercial funding. 30% have Medicaid. 30% have some other form of underfunded Medicaid or Medicaid Plus. And the remainder of that have essentially no funding. So when we're talking about applying these applications and based upon race and ethnicity, it becomes incredibly important to account for facilities that deliver that kind of care. So in summary, so that we try to stay back on track, there are limited publications to date, but they've demonstrated differences in outcomes in patients, and they may potentially be associated with gender, race, and ethnicity. I say potentially because I don't think the associations that we've seen so far allow us to make anything beyond that in terms of a statement of the data. In patient care directed at cardiogenic shock, it appears to differ. So whatever we're doing, we do it differently. It's critical to disentangle the socioeconomic issues, access, patient phenotypes, and patient desires, by the way, because we do see differences in expectations and what and how they want to be treated in those groups. And they are true confounders in this patient population. And we always ask for, but I think it's true in this case, larger studies in appropriate locations, we don't often make that statement, which are adequately powered with specific data points looking at race, ethnicity, and decisions. And we need the longer term outcomes because we do know that how people that are non-white are taken care of at home, the resources that are there and other things impact how they do. And I think while we don't have the data, there's a big concern about that. And so I think these trials that are going to be developed, looking at longer term outcomes, are going to be incredibly important in helping us address the disparities that we believe to be there by first identifying them and then identifying options for treatment. Thank you very much. I appreciate your attention.
So at least to me, I think it's a very persuasive case that we are lacking important information about outcomes and strategies in underrepresented populations. And so I'm going to do what a moderator gets to do. I'm going to look to my left, and I'm going to ask whether any of my panelists have suggestions about how we might go about doing better here.
So I'm going to start by maybe conceptualizing what cancer did, right? Now, cancer concepts started with developing the center accreditation and then looking at whether the hub and spoke existed in each geographical area with a proximity that was acceptable or meaningful. And I wonder whether, the inequity that you clearly represent over here, which we're very familiar with, especially for advanced care, is to the degree that we don't even capture the data. It's obviously now that now we see whether we would want to do a call for action. We have the same, overlapping data with TAVR for, durable mechanical circulatory support, for transplant, everything else. For advanced care, we don't have, pretty much we don't provide it. There's no access to it for underrepresented minorities or variety of individuals with poor access. So the concept is whether we need to develop the centers, accredit them, put them on a map, and make sure that everybody in its proximity has it. Then we'll talk about the payer and other coverage. First, identify who provides it.
Yeah, and I also think, you brought up an important point about identifying centers that are located in areas that are richly populated with diverse communities, but I would also add that we need to have leaders and investigators on these trials, designing these trials, who equally represent the populations that we're trying to enroll in these studies. And we really have suffered in that regard from a sex disparity difference and an underrepresented minority disparity difference.
Yeah, I would extend that. I would love to, I believe, and we're working towards that we need to include community members, not just physicians,
yes.
but community leaders, whether it's the health department of your state or certainly people who are knowledgeable on those designs as well, because I think they will inform us about areas that we haven't even begun to touch.
Yeah, great idea.
And what we need is the lawmakers on there. We need the lawmakers on there too, because our hands are many times strapped, that we don't have the resources to take care of every underserved patient.
And I think if we do some of the data you're talking about, we can show the economic cost to those areas that would convince the lawmakers that contributions to help with this, not just going to the NIH and writing a trial, but actually looking at more grassroots support would be there.
Steve, I was just struck by two things from your talk, and one thing Bikram actually brought up. Let me start with the slide that showed, in that huge database, you're going to find statistically significant differences in the end organ differentials. And that's true of any huge database, but what struck me, if you look at the point estimates, neurodysfunction and renal dysfunction in African Americans enriched for injury. So if you start asking me I think what we have to start doing in this field is a lot of fields put together, is start asking what do we need to know? Not what's useful to know, what do we need to know? Anybody can design a trial of something that could be useful, but do we really need it? I mean, so that is very important. And I think that is where, in my opinion, just to tie it with Beacon's comment about regions and enriched populations, I think like Intermax is trying to come up with a way to put registry data into tiered, call them departments, call them in other words, you could have 10 sites that are focused on one tier of interest. I think this is going to be important for shock, is you have the tier that's looking at, injury or harm potentially from either device or medical therapy. Which one is what, based on those adverse events that we need to know. If you ask me what the common issue between kidney and brain is, it's autoregulation. African Americans, we know, don't autoregulate. To some degree the same, and it has probably to do with their hypertensive, maybe the way that they adjust to their hypertensive, more predominant nature.
There's so many questions that come out of this, aren't there?
There's such disparities in this, shock is a very difficult entity to treat even in the best possible scenario with the most enlightened population. With the COVID, which we are just recovering from, has thrown a light on this disparity so much more. COVID is not an equal opportunity virus, and it has just magnified this health differences between ethnicities. Blacks form 15 to 18% of the population, but 40% of the mortality is amongst blacks. Vaccinations, 80% of whites are vaccinated, and the vaccination in blacks are in teens, and not even teens, single digits, 8% to 9%.
That's a whole different.
So when you have those kind of disparities, to translate that into disparities into shock is going to be even more monumental.
It will be, and I think the philosophies, the socioeconomic features that result in decisions are huge impact on this too.
So just one more. Dr. Schraga, I think I'm going to put you on the spot. You come from a place with a universal health service, and I'm sure there are disparities in Germany as well. But I wonder if you could refract the issue of a universal health service and how that helps you address disparities.
I think what's interesting in this regard, and this now doesn't directly relate to cardiogenic shock or MCS, but to devices in heart failure with reduced ejection fraction, that when we look at, and this is Sweden, not Germany, but a similar universal healthcare system, you would think that in a universal healthcare system, you do not have differences related to socioeconomic status or race or ethnicity, but we still do see them. There are so many analyses on that showing that device use is less likely when you have lower income, when you do not have a university degree, or when you're living alone. That I think this is not all explained by the way the treatment is paid for, but this is more than that. And it's oftentimes I think it's access to care and just getting to the doctor or getting to the right doctors.
And I think the other piece of that, if I could just make the comment, I think it's also on what your end game is, right? That was brought up earlier. What is your exit strategy? And, are we disadvantaging people because we think they're not going to have the same option for an exit strategy?
Yeah.
May I just also add that for those that are in the rural or due to distance unable to access, or those disadvantaged populations where there is not an advanced center in nearby, whether the kangaroo care, going there, putting the things percutaneously and bringing the patient back. I'm going to put Biswajit on the spot because I know there are models for that, whether we could start looking into feasibility, outcomes, and elimination of disparities with such models where you're getting the patient and bringing back, because that's maybe a mitigation strategy that I see pediatrics doing.
So you're asking like a level 1 trauma, level 2 trauma center?
Yes, but going and intervening as a MASH unit, you go with your gadgets, go and intervene there, you do it, and then bring the patient back for the advanced care. And we may need to look into those models and demonstrate that these actually eliminate disparities and delays and adverse outcomes potentially.
We have that. We have a mobile VV, and now we're starting a mobile VA. But the biggest question is there an exit strategy before we go out there for that patient?
Yeah, that's becoming.
Well, thanks so much.
Thank you all. I appreciate the opportunity.
Appreciate it.